here with Catholic Health Services. So what is lung cancer? So lung cancer is the uncontrolled growth of abnormal cells in the lungs. These abnormal cells may form into tumors that may interfere with normal lung functioning. And although lung cancer is most treatable at its earliest stages, only 20% of patients are diagnosed at that time. So unfortunately, most patients are diagnosed with late-stage lung cancer. So before time, we used to hear that a friend or a relative was diagnosed with lung cancer and they died shortly after. Why? Because we didn't have this type of screening many years ago. So some of the facts about lung cancer. It's the leading cause of cancer death in the United States and worldwide. It claims more lives than breast, colon, prostate, and pancreatic cancer combined. It can often be cured with surgery if it's found at an earlier stage. Smoking is the largest risk factor as it causes 85% of lung cancer cases. And the scary part about it is that patients with early stage lung cancer may have little to no symptoms at all. So some of the signs of symptoms of lung cancer. So we have coughing up blood or rust-colored phlegm, insignificant, unintentional weight loss, new or changing cough, new shortness of breath, chest pain, fever, or hoarse voice or voice changes. So since this is a screening program, we're trying to screen patients before they have these symptoms of lung cancer. So who should be screened for lung cancer? This recently changed. So as of March 9th of this year, they lowered the age to age 50. So you have to be between the ages of 50 and 80. You can be a current smoker or have quit within the last 15 years. You also can have a smoking history of at least 1 pack a day for 20 years or 2 packs a day for 10 years. And most importantly, you have to have little to no symptoms of signs or symptoms of lung cancer. And you have to be willing and able to participate in testing and treatment if needed. So why are we doing this lung cancer screening? So advances in medicine and technology have allowed us to detect lung cancer well before symptoms are present. So they did a national lung cancer screening trial with over 50,000 participants. And they found that using this low dose CT scan in comparison to a standard chest x-ray significantly reduced lung cancer deaths in heavy smokers. So since that trial, lung cancer screening has become a national preventative health recommendation. And that is why it's covered by most insurances, including Medicare. So what is screening? So screening may detect disease prior to having symptoms. It uses this low dose CT scan to look for early stage lung cancers. And it's recommended every year and is a long-term commitment for eligible individuals. But the thing that you have to remember is that just because you get screened, it's not a substitute for smoking cessation, as quitting reduces the risk of developing lung cancer. So what are the risks that come along with lung cancer screening? So there's false alarms. So that may be false positives or false negatives. There is overdiagnosis. Are we looking at something that may not cause you a problem over your lifetime? But that's generally in our elderly individuals. There's radiation exposure. The studies on the exposure of radiation from the low dose CT scans are very weak. And we may still miss lung cancer because there's two different types of lung cancer. There's small cell lung cancer that's not going to be picked up on this type of scan. And then there's large cell lung cancer that forms into tumors. So that's what we're checking for. So this may lead to invasive procedures such as biopsies or surgery, additional CT scans, the psychological distress that comes along with getting screened, waiting for your test results, etc., and other complications as a result of procedures such as bleed infection or collapsed lung. So this slide is about comparing our radiation sources. So below you'll see the amount of radiation that we get from air travel. It's very low. It's around 0.04 milliverts. And that's the amount of radiation that you get from 10 hours of travel. That's why it's also important when you are flying to wear sunscreen because you're closer to the sun. Then you see the amount of radiation you get from a chest x-ray, then a mammogram, and then the low dose CT for lung cancer screening is around 1.4 millisieverts. But look to the right of it. That's the average amount of radiation that you get in your background environment every year. So it's significantly higher. So what about other comorbidities? So the potential harms of lung cancer screening may be greater if you have other health problems, such as severe heart disease or severe lung disease, because the risk of complications from biopsies may be greater in these individuals. But as you know, medicine is catered to the individuals nowadays, So when we go for surgeries, we have to get clearance, correct? Clearance from maybe our cardiologist or maybe from our pulmonologist, etc. So what are the benefits of lung cancer screening? So the benefits may be greater if your lung cancer risk is higher, which it is in these individuals. So the benefits of lung cancer screening include better quality of life with early detection, greater chance of not dying of lung cancer because we potentially caught it earlier, and detection of other diseases other than lung cancer. Because we're looking at the chest cavity, we can see other structures next to the lungs. So we can see the heart potentially. We can see if there's calcifications in the arteries. For example, we can see the thyroid. We can see if there's nodules. We can see your gallbladder potentially on the way that you're positioned. So it's not just about detection of lung cancer, it's about detection of other diseases as well. In this program, we've found breast cancer in males and females. We've found adrenal tumors, lung nodules, as well as other incidental findings that weren't attached to the screening process. So this is a slide about the number of lives that will be saved with lung cancer screening. So out of 1,000 people not screened with the low dose CT for lung cancer, 21 people will die, versus out of 1,000 people screened with a low dose CT for lung cancer screening, 18 people will die, and 3 lung cancer deaths will be prevented. I know you're saying to yourself, only 3, but I feel like most of our patients would want to be one of those 3. So how is the low dose CT performed? So the scan takes approximately 5 to 10 minutes. It involves laying flat on a CT table. There's no need to fast, no injections or other medications. And most importantly, it's painless and non-invasive. So what happens after? So each scan is reviewed by a radiologist that specializes in reading lung nodules. Then you'll be contacted by me, and I will mail a letter with your results to your home via U.S. Postal Service. I will also contact your primary care provider and or your referring provider to notify them of your radiology report results. Annual visits will be scheduled by our nurse navigator until you no longer meet criteria. And then the thing that you have to remember is that a normal result may mean that your risk of lung cancer may be low, but not necessarily zero. So that's why you have to keep coming back because the risk of developing lung cancer, although it's low, annual screening is necessary. So what happens if you have a abnormal low-dose CT? So an abnormal result doesn't necessarily mean you have cancer, and we stress that immensely. Additional testing may be needed to determine what's going on. So if an abnormality or an incidental finding is detected, incidental findings mean, so we're screening for lung cancer, and we find that you have calcifications in your arteries. So that's an incidental finding, an example of an incidental finding. So we will arrange for you to follow up with a specialist based on an incidental finding that we find. So for example, if we find calcifications, we might refer you back to your cardiologist or refer you to a cardiologist, etc. And then we use evidence-based recommendations that we provide to your referring provider for follow-up. So lung nodules. Lung nodules are the most common non-cancerous low-dose CT abnormality found in former and current smokers. We generally find them in 51% of patients. So over half the patients we screen, we find lung nodules. However, if they are cancerous, this is a stage where treatment may be very successful. Most of the ones that we find are usually benign, which means non-cancerous. So these lung cancers are lung nodules, are most often the result of old infections, scar tissue, or other causes. But additional testing is often needed to make sure that the nodule is not cancerous. So most often, the next step is to repeat the low-dose CT scan to see whether or not it's growing over time. Because earlier on, we said that lung cancer is the uncontrolled growth of abnormal cells. So growth, especially with a lung nodule, is not good. So the time between these scans may range from anywhere from a few months to a year, depending on how likely the radiologist thinks that the nodule might be cancer. And this is based on the size, shape, location of the nodule, and whether it appears solid or fluid filled. If the nodule is larger, the doctor may recommend additional imaging, such as a PET scan, which will help to determine whether or not something appears to be cancerous or not. So how do you lower your risk of developing lung cancer? 8 out of 10 cases of lung cancer in the United States are from smoking. So if you're a former smoker, it's important to remain smoke-free. If you're a current smoker, smoking cessation will reduce risk of developing lung cancer. And we at CHS offer smoking cessation programs throughout Suffolk and Nassau County. So in summary, lung cancer develops over time, and screening is most effective when it's performed every year until you no longer meet screening criteria. That's when you age out, when you are you turn 81, or if you become more than 15 years smoke-free, you lower your risk. And we are here to partner with you on this lung cancer screening journey. So our team of lung cancer screening navigators, we provide up-to-date information about screening and test results. We work with a multidisciplinary team of health professionals to address suspicious findings. I'm paired with a pulmonologist at each site that we scan with, that we scan patients. We also have an interventional pulmonologist, a part of our team, as well as several thoracic surgeons. We use evidence-based guidelines to avoid unnecessary procedures. We assist in reducing the stress of lung cancer screening process, assist with smoking cessation, and we also remind you of your regularly scheduled screening appointments. Okay, see if this works. So I'm trying to cue a video of a patient that we saw for lung cancer screening.
We can't hear that. We can't hear it or see it.
Oh, okay. Okay, I'm sorry. Okay, I guess too many technological difficulties. So any questions?
Sylvia, is it one with Geraldine Kennedy? Because I can share the link in the chat box for anyone who wants to watch it after the
Okay, perfect.
Okay.
So that concludes my presentation about lung cancer screening. Any questions?
What's the difference between small cell and large cell?
So small cell, it's not going to be picked up on a low dose CT because the cell size is very small. Large cell is what's going to form into tumors or nodules, and that's going to be picked up on a CT scan. So large cell is normally from smoking. Small cell can be from smoking or other causes, genetics, different things.
So small cell doesn't evolve into large cell. They're two different things.
Not two different things. And small cell is more aggressive than large cell.
This is a very heavy topic.
Yes, it is. Very serious.
And it has to be done every year, right?
Yep, until you no longer meet screening criteria. So when you're greater than 15 years smoke-free, or when you turn age 80, you aren't eligible anymore because your risk is lower.
Thank you.
You're welcome.
Okay. Anybody else have any questions? All right. Well, thank you so much.
You're welcome.
This was very informative. And I will have the recording sent to you, and I will have it up on the JCC website as well.
Great. Thank you. Be well.
Thank you, doctor. Have a good day.
All right.
You too.
Thank you so much.